Thank you, Chairperson. And at the outset, I would like to thank the organizing committee of Team Avatar for giving me this opportunity. And I have been asked to talk on this topic of a complement, its role in ABO-incompatible transplant and rejection. What is the pathophysiology and how to use it for our patients? So, as all of us know, that kidney transplantation is the best form of kidney replacement therapy for a patient who reaches end-stage kidney disease. But unfortunately, almost 30% of willing donors have incompatible blood group. So the options for such incompatible pairs remain either a paired kidney exchange, ABO-incompatible transplant, or remain on the wait list and wait for a deceased donor. The paired kidney exchange, although a better option, it's not always feasible, and the blood group O is disadvantaged in this. And the ABO incompatible transplant has been shown to increase the survival rate from 50 to 90% when compared to remaining on the waiting list for a deceased donor. So the initial attempts at ABO incompatible transplant was found to be unsuccessful. And in fact, the first real successful ABO incompatible transplant series was published in 1987 by Alexander et al. And he has used splenectomy and plasma exchange to attain this. From that time onwards, Japan, a country where the disease donor program was not successful, took over, and the ABO incompatible living kidney donor transplant became pretty successful over there. The preconditioning regime, which has been used since then, consists of regular plasma exchange, double filtration plasma exchange, or immunoadsorption, IVIG, splenectomy, and lately from 2004-5 onwards, rituximab. Slowly, this has spread worldwide from Japan to Europe to US and India and other places as well. And now it constitutes almost 10 to 30% of the kidney transplant in various programs. There have been significant advances in the preconditioning and immunosuppression protocols, and the patient outcomes have been at par almost with the ABO compatible, but the graft survival still continues to be lower. And why does this happen? This is because of the initial dip that we see in the graft survival, which happens because of the antibody mediated rejection in ABO incompatible transplant. And after that, as you can see, the outcomes are as good as the ABO compatible ones. And this has been reported in almost all the cities. This is a meta-analysis by De Weerd et al., which was published in Clinical JASN, and where he took various studies where ABO compatible and ABO incompatible transplant outcomes were compared. And as we can see, the AMR was higher definitely in the patients who underwent a ABO incompatible transplant. So the AMR in ABO incompatible transplant, it is an unpredictable and sudden phenomenon and often leads to graft loss. It classically happens within the first 2 to 3 weeks before accommodation sets in. And there is no correlation with the baseline titer of the isoagglutinin. And sometimes there is a sudden explosive increase in the titer which accompanies these rejections, but this may not be always the scene. And most of the series have reported thrombotic microangiopathy as the predominant finding in the biopsy. So what is happening is the preformed natural anti-blood group antibodies, they attach to the blood group antigens on the surface of the graft endothelium, and it leads to the fixation of and activation of complement, microhemorrhages, thrombosis, and ultimately graft loss. So this is the complement system, and as we know, there are three ways of activating the system. First one is the classical pathway. The second one is the lectin pathway. Third one is the alternative pathway. In ABO incompatible transplant, the classical pathway is activated, which is because of the antigen and antibody complexes. This is recognized by C1q, which is a pattern recognition molecule, and it activates C1r and C1s, which leads to the formation of C4b, C2a, as it is a protein serine protease, and this leads to the cleavage of C3 into C3a and C3b. C3a is an anaphylatoxin, and C3b once again combines with C4b, C2a, and this is what we say C5 convertase. And this is the terminal pathway when the C5 is converted into C5a, C5b29 membrane attack complex. And this finally is the final effector pathway leading to the endothelial damage and the graft loss. There are various regulators, or what we say inhibitors, which prevent this spontaneous activation of the complements in a normal person. So what is the role of this complement in ABO-incompatible transplant? The anti-blood group antibody, the complement can get activated due to many reasons in ABO-incompatible transplant. The most important one of that we have discussed already. And apart from that, there can be exposure of, there is an exposure of blood and plasma to the artificial surface during extracorporeal apheresis that we have to do. The surgical trauma and the ischemia reperfusion per se can lead to activation of complements. The binding of antibodies to the ABO determinants in affinity column of immunoabsorption can lead to that. And last but not the least, even the medications like CNI can lead to this. Not only antibody-mediated rejection, it has been found that complement has a role even in the T-cell rejection. There was a series of 27 ABO-incompatible transplant where the authors did indication as well as protocol biopsies, and they did immunofluorescence, and they looked for complements, the products like C4D, C1Q, C3C, C5B to 9. And what they found was that there was a higher rate of T-cell mediated rejection in their series, although this has not been the consistent finding in other series. But interestingly, the complement component C5b29 was more intense in the indication biopsies where you had a rejection, T-cell rejection that is. And as predicted in earlier series as well, there was no correlation with the C4D. So this happens because the complement inhibition is incomplete, and even the C5a can lead to the T-cell activation. Few words about accommodation in ABO-incompatible transplant. Accommodation is a phenomenon by which graft rejection is avoided despite the reemergence of incomplete antibody, and has been classically defined as structurally and functionally normal graft in presence of C4D in the blood vessels. There are various mechanisms of accommodation, and one of the proposed mechanism is a complement inhibition, which is because of the expression of complement regulatory proteins such as CD59, which classically inhibits the formation of C5b to 9 membrane attack complex. Now, there was this particular study where they looked at the transcriptome analysis of patients who underwent a ABO-incompatible transplant or HLA-incompatible transplant. They did protocol biopsies at 3 months, and they looked for what were the transcriptome analysis. And what they found was, interestingly, in patients undergoing ABO-incompatible transplant, CD46 and CD59, these complement regulatory transcripts were upregulated, while in HLA-incompatible transplant, CD46 was solely upregulated. Now, the function of CD46 is to cleave C3b and C4b, and thereby it regulates only the proximal complement activation cascade, and it leaves the distal one, which can still get activated and lead to rejection. While the CD59 inhibits the distal part of cascade and membrane attack complex formation. The complements have been found to have a role even in the phenomenon of accommodation, as we discussed already. And there was this study where they had compared HLA incompatible as well as ABO incompatible transplant. At the end of 3 months, they did protocol biopsies, and what they found was that the regulatory transcripts of CD46 and CD59 both were upregulated in ABO incompatible transplant, while in the HLA incompatible transplant, only CD46 was upregulated. Now, the CD46 has a role to cleave C3b and C4b, thereby regulating the proximal complement activation cascade. But the CD59 inhibits also the distal part, and thereby, if both are upregulated, then it has a role to play in the accommodation. While if only CD46 is upregulated, the complement pathway can still be activated and can lead to rejection. So, having gone through the pathophysiology and the role that complement plays in the rejection in ABO compatible transplant as well as accommodation, let's see how we can use this for the benefit of our patients. So, the complement modification for ABO incompatible transplant can be done by two methods. One is what I will say specific therapy, which the only one is eculizumab, and other are non-specific therapies like rituximab, immunoadsorption, plasma exchange, and IVIG. So first of all, eculizumab. Eculizumab is a recombinant, fully humanized monoclonal antibody against C5. It binds to C5 and inhibits its cleavage by C5 convertase, thereby preventing the pro-inflammatory, pro-thrombotic, and lytic functions of the complements. In transplants, it has been used for the prevention of antibody-mediated rejection and also as a rescue therapy. It has been classically used in atypical HUS, and in transplant, it has been used for the prevention of the recurrence of this atypical HUS as well as the treatment. Similarly, in ABO-incompatible transplant, it has been used as a rejection, AMR prevention, and rescue therapy. The first initial use of eculizumab in AMR treatment in ABO-incompatible transplant was reported in as early as 2011. And since then, there have been quite a few case reports, and where the authors have used eculizumab in various dosing regime. As we see in the first one, which was a combined pancreas kidney transplant, they used eculizumab in 600 milligram on POD10 and POD14 with a stable graft function at 6 months. Similarly, in Stewart et al. Publication in 2012, he used 3 doses of alternating eculizumab with plasma exchange, followed it with POD 14, 21, 28, 43. And the creatinine was 2.6. Patient could be successfully revived from dialysis. And in another one in 2017, published by Lanfranco et al., they used 900 milligram of eculizumab weekly for 4 weeks, and then 1200 milligram every 2 weeks, and this went on till day 64. One of the graft was lost slowly, but another graft had a stable graft function at 13 months. So we can see that it has been used successfully for the treatment of antibody-mediated rejection in ABO-incompatible transplant. Not only the rejection treatment, but also for the induction of accommodation and the prevention of rejection, eculizumab has been used. And in fact, there was this study on mice model where they used a mice for ABO-incompatible heart transplantation. And there was 4 group of these mice. One received no immunosuppression, one received conventional immunosuppression with tacrolimus, mycophenolate steroid. Third one received C5 inhibitor eculizumab, and the fourth one was a combination of all the therapies. And as we can see that the best graft outcome was in the fourth one with the combination therapies. And this figure shows that at day 7, the infiltration of T cells, B cells, as well as macrophages into the heart allograft was minimum in the combination group. And when they assessed the activated splenic cells as well as the cell secreting inflammatory cytokines, these all were minimum in the combination group. Taking a leaf from there, this group by West, they published 4 ABO-incompatible living donor kidney transplant report where they have used eculizumab in pre-op day 1, post-op day 1, 7, 14, 21, 28, 35, 49, 63, along with the preconditioning regime, as well as induction of 5 doses of 1.5 milligram per kg of rabbit ATG. And they used tacrolimus and mycophenolate as maintenance, but tapered and stopped steroid. As we can see, the titers of most of the patient, 3 out of 4 remain stable. One patient had a rebound in the titer, but the authors could successfully stop eculizumab in all of them, and the graft function was stable for all. One patient had ATN and had prednisolone had to be restarted in this patient. One patient had severe infection form of UTI, C. diff, as well as resistant CMV. So I went through this, if there was any trial for eculizumab. So there is this one trial which was planned for use of eculizumab in prevention of antibody-mediated rejection in ABO blood group incompatible living donor kidney transplantation. But unfortunately, it couldn't go on because of the poor enrollment. It had planned to enroll 20 patients, but could enroll only 6 patients. And although it was not published, but then you have data on what happened to the 6 patients. There were serious adverse events in 5 out of these 6 patients, almost 80%. And as we can see, 2 out of these 6 patients underwent allograft nephrectomy, which was most probably because of the antibody-mediated rejection itself. So as we can see, it could not completely prevent antibody-mediated rejection. So why is it that it is not always effective? There have been a few theories. One is there can be a genetic variations in complement 5, and this can lead to a poor C5 inhibitory response by eculizumab. Second thing is there are factors which can act downstream, and AMR can still be triggered by the upstream immune modulators, such as C4A and C3A anaphylotoxins. Thirdly, there can be a high C3 turnover because of strong complement activation, which can kind of overwhelm this eculizumab. And fourth, it cannot prevent the damage, which is because of the innate immunity by natural killer cells and the macrophages. There are other issues, such as most important was the cost and the availability. It's not available here in India, and it's pretty expensive therapy. There can be nasty complications, including infections with encapsulated bacteria as meningitis, strep pneumoniae, H. influenzae, as well as aspergillus infections. We still don't know what is the best regime to prevent or treat AMR if it happens in these patients. And also, all these patients should be vaccinated in advance whenever we are planning to use eculizumab. So there are other ways also of complement modification in ABO-incompatible transplant, as we discussed: immunoadsorption, plasmapheresis, IVIG, and rituximab. So there were these studies where it was seen that the plasmapheresis can reduce the complement factors C3, C4 by almost 35 to 40%. There was this interesting study of desensitization with antigen-specific immunoadsorption. And here the authors looked at the complement activation characterized by after immunoadsorption in 19 patients. They serially measured the complement C3, C3A, and the ratio, as well as C5b to 9 and C1q from day minus 30 to day 30 of transplant. And what they saw was C3A, C3A by C3, C5b to 9 declined and was maintained post-op throughout day 30. What they did is they took out the eluates from the immunoadsorption column, and they found that these complements were present in that eluate also, showing their role in the adsorption of this. The graft and patient survival was 100% in this series, and there was no antibody-mediated rejection. So even the immunoadsorption can reduce the complements. There have been studies about role of IVIG in complement inhibition, where the sera of patients treated for antibody-mediated rejection with IVIG was assessed before and after treatment. And IVIG was consistently shown to inhibit the complement activation starting shortly after infusion, and it lasted almost 2 to 4 weeks. And similar study has been even done in xenotransplantation models. There have been studies on rituximab, and rituximab also has been shown to promote rapid complement depletion and acute CD20 loss because of its function in patients with chronic lymphocytic leukemia. and can have similar role even in patients who undergo ABO-incompatible transplant and receive it as a part of a preconditioning regime. So these are the available things and what we are doing, but now coming to something which is on the horizon, although not so far used in ABO-incompatible transplant, but then it is being tried in HLA-incompatible transplant to prevent and treat antibody-mediated rejection. One of them is the C1 esterase inhibitor. This is a serine protease inhibitor, and it has been used for angioedema type 1, type 2 treatment. It blocks the classical pathway. It inactivates C1s, C1r, and it also has a role to play in the lectin pathway of the complement. Another molecule is complement type 1 receptor, microcept. This once again is a natural membrane regulator of complement, and it has been seen to inhibit both classical as well as alternative complement activation pathway. Both these agents are being tried for treatment of antibody-mediated rejection in HLA-incompatible transplant, although so far not used in ABO-incompatible transplant. So my take-home message is acute rejection remains a major limitation of ABO-incompatible transplant despite increasing popularity. And complement pathways have an important role to play in acute rejections in ABO-incompatible transplant. Complement inhibitors, as we know, can help in accommodation induction as well as treatment of rejections. But the availability of these agents, specifically eculizumab, which is the one which has been used, and the cost and the complications, all of them remain important concern. And we definitely need more studies in this regard. Thank you so much. And I would be happy to take any questions.